Welcome to Clinical Reasoning Rounds, Episode 9. Today, we're practicing the art of reading signals correctly. Throughout this video, we'll encounter 5 common signs that point to entirely different diagnoses than you might first expect. Remember to commit to your diagnosis before each reveal, and always question the initial attribution. For education only, not medical advice. Let's round. Our process follows a clear structure: history, examination, investigations, and then your moment to decide. Pause the video and commit to a diagnosis before we walk through the reveal and clinical pearls. The key today is to read the signal beneath the sign, as 5 times in this video, the signs are lying to you. Here is our case board for today. We have 5 patients, each presenting with a sign that was misinterpreted by the patient, their family, or their clinical chart. From abdominal pain to unexplained unconsciousness, our goal is to find the true signal in each case. We start with Case 1. Case 1 involves a 44-year-old woman suffering from 18 hours of escalating epigastric pain that radiates through to her back. She's been vomiting and feels feverish. On examination, we see strange, bruise-colored discoloration on her flanks, despite no history of injury. Let's look closer at her history. Her history reveals 4 key threads: the current severe pain, a previous milder episode that went uninvestigated, a daily habit of alcohol and smoking, and a lack of other significant medical history. That previous, milder episode should have been our warning. Now, examine the clinical findings. Her vitals show a fever, a fast pulse, and sliding blood pressure. There's fluid at the left lung base and peritonism in her abdomen. Most notably, we have those flank bruises. Remember, a bruise is blood in the skin. If there's no trauma, that blood is leaking from something deep inside. What do these labs tell us? The laboratory results show high inflammation and signs of plasma loss. Hemoglobin is abnormally high due to concentration, and urea is rising. We have localized inflammation near the stomach and back. Based on these findings, can you identify the specific organ and the underlying process? Take a moment to pause the video. Based on the trajectory of her pain, the flank bruising, and her laboratory profile, what is the diagnosis? What confirmation test is needed, and how do we assess the severity? Your clues are on the table. The diagnosis is acute pancreatitis. The inflammation of the pancreas, which sits behind the stomach, explains the pain's path to the back. Amylase or lipase levels are key diagnostic tools. The flank bruises, known as Gray-Turner's sign, are a clear indicator of severe retroperitoneal hemorrhage. Pancreatitis can escalate quickly, so we use scoring systems like Ranson criteria to assess severity and guide management. Severe disease can lead to systemic complications like shock, organ failure, and metabolic issues like hypocalcemia, as the leaked enzymes interact with surrounding fat. Management relies heavily on aggressive fluid resuscitation. Antibiotics aren't routine, because this is primarily a chemical process, not an infectious one. Always keep these pearls in mind. Back boring, epigastric pain, and internal bruising are critical signs. Now let's move to Case 2. Case 2, a 62-year-old woman, 10 days post-bowel surgery. She was doing well until day 5, when fevers appeared. Now her blood pressure is dropping, she is jaundiced, and her urine output is critically low. Her creatinine has risen sharply. We need to identify the factors behind this rapid decline. Looking at our timeline, the patient had a bowel resection, followed by a persistent ileus. Fevers were addressed with gentamicin, but her condition worsened. The development of hypotension and acute kidney injury after day 5 is significant. Let's examine her current status. Examination reveals a failing circulation and jaundice. The abdomen is tender at the surgical site, and bowel sounds are absent. This combination of fever, jaundice, and guarding in a postoperative patient strongly suggests intra-abdominal sepsis. The liver is struggling under this septic stress. Finally, review these laboratory findings. The massive jump in creatinine, combined with acidosis and evidence of acute tubular injury in the urine, confirms severe renal damage. With blood cultures negative and high gentamicin levels, there are at least 2 clear assassins responsible for this clinical picture. What are they? Pause the video and consider the case. Why are her kidneys failing? And what is the trap in that rising trough level of 4.8? Set your priorities for her circulation, renal replacement, and source control. Use the clues: anastomosis guarding, absent bowel sounds, and jaundice. You must count the assassins. Her kidneys were killed by committee. First, intra-abdominal sepsis from an anastomotic leak. The sepsis syndrome is evident across her vitals and labs. Second, gentamicin toxicity, which peaked during her 10-day window. Remember, A rising trough means falling filtration. The number is a rearview mirror, not a preventative tool. Management requires stabilization in the ICU with invasive monitoring. For renal replacement in an unstable patient, continuous hemofiltration is safer than intermittent dialysis. Finally, source control is mandatory laparotomy to drain the pus and defunction the bowel. Pus must be drained to stop the sepsis. 3 pearls. Postoperative kidney failure is a committee crime. Sepsis has quiet signs beyond fever, like hypoglycemia and falling platelets, and drug levels lag behind the actual damage. Recognize the pattern and act decisively. Next, we turn to a blush that was not caused by embarrassment. Case 3. A 64-year-old retired school secretary with abdominal discomfort, diarrhea, and a facial flush. Her husband notes the flushing occurs during her painful episodes, but she dismisses it as embarrassment. Always look for the signal behind the explanation. The blush is chemistry, not psychology. The history presents 4 distinct threads: chronic abdominal ache, new crampy pain with diarrhea, episodes of facial flushing, and recently, unexplained wheezing. At 64, a new wheeze in a non-asthmatic patient is a red flag. We have a set of symptoms that form a very specific pattern. Put the symptoms together: flushing, cramps, diarrhea, and wheeze. Each could be benign in isolation, but together, they form a fingerprint of something releasing hormones in bursts. What substance causes these symptoms when it enters the circulation? We need to find the source of these hormonal pulses. Imaging revealed a solid, space-occupying lesion in the liver, suggesting a metastasis from a primary tumor. We must identify a gut tumor that remains silent until it reaches the liver. She has no risk factors for exotic infections, keeping our focus squarely on oncology. Pause the video. Can you name the syndrome and the tumor? Why are there no systemic symptoms until the liver is involved? Identify the confirming 24-hour urine test, how to get tissue-proof, and a drug to control these episodes. The clues are on the table: count, sequence, commit. The diagnosis is carcinoid syndrome from a neuroendocrine tumor of the small bowel. It remains silent because the liver neutralizes the secreted serotonin in the first pass. Only when the tumor metastasizes to the liver does it bypass this filtration, allowing the hormones to reach systemic circulation and cause symptoms. Confirm the diagnosis with a 24-hour urine collection for 5-HIAA, which measures the breakdown products of serotonin. Tissue is obtained via liver biopsy. Manage the symptoms with octreotide to block hormone release, and consider embolization by interventional radiology to shrink the tumor deposits. 3 pearls. This quartet of symptoms, flushing, diarrhea, cramps, wheeze, should always trigger a carcinoid workup. Never settle for the patient's explanation when family observations are more accurate. And remember, the syndrome's onset often signals that the disease has progressed to the liver. Next, a case of 48 silent hours. Case 4. A 28-year-old woman found unconscious after 48 hours. Her partner admits to their shared history of intravenous heroin use. She is currently unresponsive. This is an emergency requiring us to read the physical signs to understand what occurred during those 2 lost days. We have a clear context: long-term intravenous drug use, with a possibility of shared needles. She is unemployed, a heavy smoker, and drinks significant alcohol. She has been alone for 48 hours. Every organ in her body will show us the story of what happened during that time. Examination confirms opioid toxicity, reversed temporarily by naloxone. We also find evidence of aspiration pneumonia at the left lung base and significant swelling in her left arm. This arm injury suggests prolonged pressure during her unconsciousness. We must investigate the consequences of these findings immediately. The largest numbers this series has shown: creatine kinase, the enzyme from dying muscle, is 68,000. Her potassium is 7.8. Her creatinine is 622, and her calcium is profoundly low. The dipstick claims 3+ blood, but the microscope sees no red cells. The stick is lying to us, reading myoglobin as blood. Pause this video now. First, name the renal diagnosis, explain the chain from her arm to the kidneys, and tell me exactly why the dipstick lied. Second, sequence the emergency treatment for that dangerous potassium, and list at least 3 other fronts: breathing, lung, and arm, that need your simultaneous, urgent attention. The diagnosis is rhabdomyolysis. 48 hours of pressure killed her muscle, which released myoglobin into her blood. Myoglobin is toxic to kidneys. The dipstick reacted to the myoglobin, showing a false positive for blood. Her calcium dropped as it was sequestered into damaged muscle. She is 2 steps from cardiac arrest. This is a 4-front war. Shield the heart with calcium, shift potassium into cells with insulin and bicarbonate, and prepare for dialysis. Simultaneously, manage her breathing with naloxone infusions, treat her pneumonia with antibiotics, alkalinize the urine to protect the kidneys, and perform a surgical fasciotomy to save her arm. Recovery requires counseling and compassion. Test for hepatitis and HIV as a routine part of care, never as judgment. Remember these pearls. Sky-high CK is diagnostic for rhabdomyolysis. Always check the pressure points in patients found down, and remember that naloxone is outlasted by opioids. Infuse, don't just bolus. Our final case brings the intensity down, but the subtlety way up. A 45-year-old secretary complains of forearm pain that wakes her at night. She has rheumatoid arthritis, but her joints are quiet. Everyone is blaming her arthritis, but the real issue is something else entirely, waiting in the dark. Her history shows 5 weeks of right forearm pain, worse at night, and interrupting her work. She has well-controlled rheumatoid arthritis and a family history of hypothyroidism and diabetes. As we move to examine her, we must distinguish if this pain is a flare of her known arthritis or a new process. Her joints show no active synovitis. They are quiet. However, she has sensory loss in her index and ring fingers and weakness in her thumb abduction. This isn't generalized arthritis. This is a specific nerve distribution. We need to identify which nerve is being compressed and why. Her blood work is mostly normal, but she has a stray MCV of 102, indicating macrocytosis. This is a vital clue. We have 3 main possibilities for this finding: hypothyroidism, folate depletion from her methotrexate, or B12 deficiency. One of these may link to her wrist issue. Final pause of the day. First, what is the diagnosis and her personal risk stack? What are the 2 classic bedside provocation tests? Second, what is the first-line management? When do you request further testing? And what must you investigate regarding that high MCV? Commit now. The diagnosis is carpal tunnel syndrome. The median nerve is compressed in the wrist's narrow tunnel. Her risk stack includes her arthritis, repetitive typing, obesity, and possibly thyroid disease. You can confirm this with Tunnell's percussion over the wrist and Phelan's maneuver, where holding the wrist flexed reproduces her symptoms. To address the MCV, order TSH, folate, and B12 levels. Hypothyroidism could link the macrocytosis to her carpal tunnel. If symptoms persist, nerve conduction studies can grade the nerve damage and distinguish this from other neuropathies. Finally, discuss weight loss to reduce the pressure within the tunnel. First-line management is simple. Rest the wrist and wear a neutral splint at night. Surgery is a last resort. Remember, night forearm pain is carpal tunnel until proven otherwise. Always give fresh eyes to new symptoms in chronic disease, and always pull the thread of a stray blood count. Here is our summary. We have practiced identifying the true signal beneath confusing signs, from abdominal pain to postoperative failure and nerve compression. Each case highlights the importance of reevaluating the initial attribution. Keep these 5 lessons with you for every new patient you encounter in your clinical rounds. Our rounds are complete. We have successfully decoded 5 complex cases. If this video helped you sharpen your clinical reasoning, please share it with a colleague and subscribe for future cases. Remember, this is for education only, not medical advice. We will see you on the next round.